Hello, this is Oleg Borisenko and Market Access Insider channel. In our programs we discuss organization and financing of healthcare services and medical technologies in European countries. Today we're in Amsterdam, Netherlands, and we're going to talk to Professor Peet from University Medical Center in Amsterdam. We're going to discuss decision-making framework for introduction of novel technologies at hospital level and physicians' perspective on that. Hope you will enjoy the program. Thank you very much for joining us on this program.
Yes, most welcome. Nice being here.
Can we start with the general overview of decision-making framework for introduction of novel technologies in the Netherlands? So how does it work at the hospital level?
Yes, so it kind of depends on where you work, but in general, all the hospitals are funded by the government and by insurance companies, and there's a system behind this. So if a new technology is available, it's made available through channels that are usually exposed to the surgeons who are working with it. If there is interest in introducing this new technique, usually the way it goes is you try to introduce the technique by talking to your department, talking to the people who are involved in the decision making. Now, this is a committee that is mainly about decisions for introducing or rejecting new techniques, and they look at finance, they look at if it's applicable to conditions that are treated in the hospital, and you have to go through a great deal to convince them that this new technique is necessary, because usually it's more expensive. We're not talking about the really big expensive things that in the university hospitals have to be a European way to look at funding. So there is this special committee that is mainly focused at is it feasible, is it safe, and how much money is involved, and is there funding?
Is there any specific evidence review process, for example, for efficacy and safety?
Yeah. So before you introduce a new technique, you somehow have to make sure that it's a safe technique for patients, of course, and for the health workers. Now, this may be difficult if it's a really new technique and we only have experimental data. So you have to make a prospective risk inventarization, and if there are not enough data, then it's probably not allowed.
Mm-hmm. And who will do evidence review? Would it be the physicians, for example, who come with this initiative?
Yes, so the physicians are the ones who should give a judgment about it, and the financials are about financing, of course. So what we have to do is want to introduce a new technique, let's say a new device that you use during surgery. It's the best way would be that some research has been done, and we try to hand it to these people and illustrate it. And make sure it's safe. If it's a really novel technique, usually we have some kind of research going on with the industry, and once the technique is proven to be safe, then we want to introduce it based on these data.
Mm-hmm. All right. Are there any specific, deadlines or timelines? Is it like annual cycle, or could you do this continuously with new techniques?
Yeah, so it is a continuous process. So there's no timeline for that. No.
All right. So could you speak a little bit about budgeting of clinical departments? So again, how is it determined? What factors play a role? And for example, if you introduce novel techniques, does it impact your budget at all?
Yes. So from an academic perspective, most of surgeons are not really busy with budgets. I'm sorry, but that's the way it is. So we see a new technique and we think, let's do it. But then, of course, there's the reality of finance. So how does it work? The budgets are, the way the budget is made up differs a little bit from the past in that there's new ways of financing now. We have to show what we do, the costs that are related to it, and then we have to find some way to have it reimbursed. Now, there is a budget, and of course, if we all introduce new techniques and the budget will go down the drain, then we have to compete with each other. So the whole idea of this committee is to evaluate what's going on and to have a fair distribution of the newer techniques. So yes, but most hospitals do have some budget for experimental stages. But if you introduce a new technique that will be, here to stay, then of course you have to make a new business case.
Right. Yeah, you mentioned very important factor is that a lot of techniques and procedures compete for the same budget. So in general, what are the principles for determining priorities? For example, we do this or that type of surgeries and how many?
Yeah, so if you have a relative small specialty and you have a big drain on the budget, of course the financials will look at you and say, is it really relevant with respect to the rest of the organization? Now, if the impact is determined to be huge, let's say a shorter stay of length of hospital stay, less pain, better quality of life, better oncologic outcomes, that may be an important factor. Whereas if a technique is introduced that just seems to be fancy and a little bit more handy for the surgeon, then of course you have to make your case. I think the most important aspect they look at is it relevant to the patients we treat, and what's the possible benefit we can get from this? Does the cost outweigh the better outcomes, for example?
All right.
Yeah.
And how important is the pressure, let's say, from the demand side? For example, there are just patients coming into the hospital. So are there any plans that, I don't know, we need to do 300 of this type of surgeries and then we just have capacity for?
Yeah. So the demand side, so looking at oncologic procedures, there's a certain level you have to reach in order to do these procedures. From the demand side, it's likely that if you, let's say you introduce a new technique for prostatic cancer and the word spreads, it's most likely that patients will want this new technique. So looking at the introduction of robotics is really an example of how it can be public driven, whereas there's not a whole lot of evidence that it's better for most surgeries. So yes, there is some impact there. On the other hand, is it likely that a new technique will attract a lot of new patients? I'm not sure. The patient organizations aren't that into new techniques in Holland, at least.
All right. So it's more, again, driven by the community at the hospital rather than from the demand side, which should be probably rather stable.
Yes, I think that's relatively stable, yes.
Mm-hmm.
Yeah.
All right. So what impact reimbursement has on the decision to adopt or not to adopt the technology?
Yes. If, let's say we have a new device and it's really costly and we want to introduce it because we think, for whatever reason, it's better, and there's no reimbursement, then you have a hard time because the money has to come from somewhere. So, so there has to be a real business case. In the old days, you could just introduce it and say, okay, it's more expensive. That's not possible anymore. Mm-hmm. So yes, it does have a huge impact.
All right.
Yeah.
All right. So in the Netherlands, there are two compartments of insurance. One basic health insurance, let's say guaranteed for everyone, and then supplementary. So if the procedure is not within basic health insurance, how often do you have individual agreements with insurance companies to cover new techniques?
I think it's not really an issue in the Netherlands, because if you look at surgical procedures, let's say you're doing some kind of a hemorrhoid procedure and you use an expensive stapler, the insurance company will reimburse a certain amount of money for that procedure regardless the technique you use. So you have to decide, am I paying more for the device and get less money out of it, despite the fact that the outcomes might be better. So I'm not aware that you can have extra insurance for special devices. That's not the situation, I think. It's the other way with some kinds of immunologicals or medical, medicine. That's a little bit different, but for devices, that's not the case.
All right. Another question on the supply side. Are there any regulations at the hospital level that determine the cap or the maximum amount of procedures you could do in certain areas?
Yes. What it used to be is that you would talk to the insurance company and they would say, if you do, let's say, 100 stomach resections, we pay you for that, and then you have to get to that target. If it would be like October and you've hit the 100, then we've had the situation that the procedures you do in November, December are not paid for. So there's a new situation in the Netherlands now for certain procedures, and you can calculate after the procedures you've done, how much you've done, and you get reimbursement for that. The thing is, there is a maximum level of money that goes into the hospital, and that's determined by budgets. So if we produce too much, let's say we operate too much, that budget, is still the same. So this will have effect on other people doing things. Mm-hmm. So yes, there is a major factor there.
Mm-hmm. All right. So can we discuss the most recent innovations in the surgical field that were introduced and their status at your hospital and in other hospitals in the Netherlands?
Yes, the main new techniques that are being introduced. Well, of course, if we talk about robotics, that's really an issue in the Netherlands with regard to that's really expensive, and it seems to be a little bit public. It seems to be a public demand. Let's put it that way. So there's a fierce discussion ongoing about the profits and the downside of the robotics. So that's really important. The other thing is the use of devices to do staplings for resections of colon or whatever you use staplers for. So there are the new devices are motor driven. Motorized devices are usually more expensive, and of course, from the environmental point of view, it's not really good. But there are a lot of hospitals using motorized stapling devices, so that's a new technique. The same goes for wound closure techniques. We used to do intracutaneous stitching, closing, but there are other devices now that can be used. So yes, there's a lot of going on as always, yeah.
Could you walk us through one of the recent examples of how the technology started at the hospital? So what were the steps and the decision-making process?
Yes, there is a device which kind of mimics the robotic degrees of freedom you have with your grasper and your needle holder. And it's, of course, it's more expensive, but it's probably, it may aid in doing a dissection and aid in the procedure. So we wanted to introduce this technique. We had to convince, of course, the committee that this technique was necessary. Now, what did we do? We looked at the literature, we looked at some research that was going on. Of course, we talked to other hospitals that were using the new technique. And then we wanted to introduce this technique. We said this money is involved, and they approved. And now this technique is under investigation. So we have some money to do a certain amount of procedures, and then we have to report back if it's really worthwhile. Mm-hmm. So that has been going on recently.
All right. So there is a concept called health technology assessment when the independent organization performs evidence review, and very often it is mostly used to inform payers' decisions. So is there any role for health technology assessment in physicians' decision making in the Netherlands, or it's not really connected?
I don't think it's really connected. No, mm-hmm. No, not that I know. Yeah,
more connected to the payers' decision making.
Yes. Yeah.
All right. So moving to the, again, self-organization of clinical communities. So what is the role of clinical societies in the Netherlands?
Yes. The clinical societies do have a major impact on the way we do procedures. So they provide guidelines. They provide the people who provide the guidelines. The thing is, with guidelines, they usually lack a few years, so they're never on top of it. So if a new technique is introduced and it's approved by the clinical societies, then you have a major argument to introduce the technique in your hospital. So that's a really important way of introducing new techniques. Yes, absolutely.
Is there any other activities, for example, I don't know, supervision of introduction of new technologies, let's say, to do it in a managed way, I don't know, to keep, I don't know, new techniques under control or something like that? Or is it mainly, again, education and clinical guidelines?
Yes, the latter, yes. Yeah.
So mostly that.
Yeah, yeah, absolutely.
Some countries have really good experience with patient registries for different reasons, for research or to inform authorities about outcomes of interventions. So what's the status of patient registries in the Netherlands?
Now, there is the Dutch Institute for Clinical Auditing, the DICA Institute, and they have registries for, let's say, certain oncologic procedures, but also bariatrics or vascular procedures. We are obliged to fill out these forms, and they are transparent, so you can see how many patients are treated in your hospital and what the main outcomes are: length of stay, quality of life, number of lymph nodes resected in an oncology case. So it's really important factor, and it's been around for quite a few years now, and it's become the backbone of registries in Holland.
So it's more for the quality assurance. Right?
Yes, it's quality insurance, but it's also the insurance companies want to make sure that you participate in this registry, because there is this peer pressure. We talk about results in groups, and they can also get information from these registries with regard to what your quality really is. So it's a really important registry, yes.
Mm-hmm. All right. So what are the biggest challenges for the healthcare system that you see, again, from the physician's perspective in the coming years?
So, of course, new techniques usually cost more. It's rarely the other way around. So we will have new techniques that will be introduced that are usually more costly, and then the question is it relevant? And if the budget doesn't go up, where do we, what decision do we have to make? So that's going to be a major issue, because the budgets are of course really tight, and there's not a lot of growth with regard to the total amount of money that's going on. So our main goal will be to look for new techniques that are really helpful for patients and for the physicians with regard to cost and what it delivers. Even more so because the introduction of new techniques is more costly than it used to be for the companies. A lot of things are going on. So I think that's a major issue. It's a major issue. Yeah.
Kind of balancing the budgets. Yeah.
Yeah.
Cost containment.
Yes.
And probably one of the final questions. So if we again can summarize, what are the important factors for consideration by clinicians when they introduce technologies? In some countries, it's mostly about clinical evidence, but in some countries also economics plays a big role. So in the Netherlands, still, is it mostly about clinical evidence and economics is left to other?
Yes. There is a change in the way we look at things. So we used to just look at clinical effects, but we were asked by the clinical societies and by insurance companies to evaluate treatments we do and look at cost and look at effectiveness. So there is a change in the way we look at things. We always just did what we thought was necessary and never considered, didn't really look at the economic factors. So yes, you're absolutely right. That's getting more popularity and is becoming more important now. But I think the main focus still is clinical outcomes. So introduction of new techniques should always lead to better quality of life, shorter hospital length of stay, things like that. Yeah.
And probably the final question: what would be your recommendations about readiness for the companies before they come to the Dutch market from the evidence perspective, or how they approach the market?
I think if a company wants to introduce a new technique, the main focus should be that this new technique really has better outcomes for the patients. And there's a strong focus for that in Holland. We're, like I just told you, not that much interested in the economic aspects, although there's a little change going on now. But our main focus is, does it really help patient outcomes? And the patient-reported outcomes are gaining popularity, so it should aid in that decision making. If a company wants to introduce a new technique, I think it's really important to find out who are the key players in the surgical field. In Holland, for example, you have to go to the clinical societies. There are always some people who are up front and people who are lagging behind. You have to find out which institution is really into new techniques, and that's probably the best introduction. So if you have one or two clinics that are willing to test it and prove that there's an advantage, then you have a strong case for it. Yes, absolutely. And what we really think is necessary is to publish it. We always try to do some research about it and publish it, and then if you can hand over the paper to the financial department, you have a strong case.
Excellent.
It's really important for us.
Excellent. Well, thank you very much, Donald, for your time.
Yes.
A very insightful interview.
Okay, thank you very much. Okay, see you.